Hello. I'd like to welcome all of you to the Community Research Academy. Today we have a great speaker with us. We have Dr. Immaculada de Melo Martin. She is Professor of Medical Ethics in the Division of Medical Ethics at Weill Cornell Medicine, which she holds a PhD in philosophy, a MS in molecular biology. Her research interests includes bioethics and the philosophy of science. Most of her work has been on ethical and epistemological issues related to reprogenetics and molecular genetics, and I hope I said that correctly. She has been particularly concerned with calling attention to the importance of science when making ethical judgments, the importance of ethics when evaluating new scientific and technological developments, and proposing public policies, and the importance of attending to the social and political context when assessing science and technology. And with that said, I'd like to welcome all of you to our Community Research Academy today with Dr. Immaculada de Melo Martin. Thank you and welcome. Here she is. The next voice you'll hear will be hers. Thank you.
Thank you, Lula May. It's a pleasure to be here. Um, so Agnes, if you, okay, great. So I don't know, I mean, right now, because I'm not sharing my screen, I can see the little squares with people's names. I don't know whether it's possible for any of you to, to show your faces, particularly during the discussion, if we want to have some discussion. If that's possible, that would be great. It's, makes things a little bit easier. But I'm going to start actually sharing my slides. What I'm going to do is give a brief introduction of what research ethics is, and in particular, I'm going to focus on research with human subjects. If it is possible, before I do that, it would be great to know just a little bit about each of you, if that's possible, so that I can have some idea of, what your experience with research might be, with research, clinical research might be, so that, during the discussion, we might have a more informed discussion, if that's okay. Anybody who would like to, I know that we probably have different screens, different people in different places. So, but if anybody wants to start, that would be great.
Hi, my name is Donna White. I have absolutely no experience with research. Just what I've done statistics in school and, just from our everyday life, but no experience.
Okay, great. Thank you.
Hi, my name is Jerisha Wilson. I'm same as Donna. I have no experience at all, but would like to learn.
Okay, that's great. That's wonderful.
Hi, my name is Paulette Spencer, and I'm a community outreach person and policy person for the Bronx Community Health Network. I don't have any specific experience with clinical research, but I've done research. So okay. I have a master's in global public health policy and management. So we did sort of a qualitative or mixed method research in West Africa on the determinants of maternal mortality. Oh. And my most recent project at BCHN was the engagement lead for the All of Us research program.
Right. Mm-hmm.
So, yeah.
That's great. Thank you.
So I guess I'll go next. My name is Jazzy, and I don't have any research experience in trials or medical. My research has been more like a fact checker, working for publishing companies. But I've moved on from there. Now I do a lot of grants and different things like that. So an application. So my research is related to that. However, when the pandemic started, I became a professional.
Very interested.
Yeah,
right.
Very, very interested in it.
Right.
I'm always interested in data and information, especially when it has to do with blood types and
Right.
various people. I've read the book, the Immortal Life of Henrietta Lacks, and I found it very intriguing. And I'll finish it. I'll finish there because I could go.
Okay. Thank you.
Thank you.
I guess I'll go next. My name is Kenny, and I haven't done clinical research, but I've been exposed to what types of clinical research does need IRB approval, like the whole schematic of it, in terms of what doesn't.
Okay, great. Thank you.
And Doctor, my name is Ms. Scanlon. My great experiment, which is also my own research, is being a human being alive and observing ethical behavior.
Thank you.
Pleasure.
I'll go. I don't have any experience in research per se. I'm a community person involved in my community. I'm a community board, things of that nature. But in particular, I live in East Harlem, and I became involved in a research issue dealing with the J. Marion Sims statue that was not far from where I live, and that led to a community effort to get rid of that statue. And that's that involves what we're going to be discussing today in terms of informed consent and all of that stuff.
Right. Thank you.
You're welcome.
Anybody else? Okay.
I have one person, they wrote in the chat. She said, "Hi, I am Mia. I have done a little bit of research in biomedical engineering, but I want to continue learning about how clinical research works and the works and philosophy behind it."
Okay, great. So I think everybody has now introduced themselves. Is that correct, Agnes?
Yes.
Yeah, okay. So I'm going to share my slides. I won't be able to see everybody when I share my slides. So if you have a question, you can either type on the chat so that Agnes can let us know, or just, interrupt me. It's perfectly okay. So again, I would love to have a discussion, a conversation, rather than just a lecture. So that would be great. So let me share my screen now. Okay, you can see it?
Yes.
Okay, great. So this is what I like to do. Just again, give a brief introduction about what research ethics is in general, all the different areas that are relevant to research ethics, and then focus on the protections of human subjects. So this is when we talk about research ethics, the concern is what researchers do. So, we obviously have ethics in many areas of human existence, but in this case, we are concerned with what researchers do, both when they do clinical research, but also when they do what is called basic research. So all of these aspects are aspects relevant to research ethics, and there are a variety of principles and regulations, federal regulations, that relate to these different areas. So questions about how the experiments are designed, how we use data, both in the context of human beings and just when we do basic research. Questions about conflicts of interest that are, becoming more and more significant. Questions about authorships and publication, animal welfare, given that we do experimentation with animals, and of course, human protections. So I'm happy to discuss any of the other areas, but because of the time, we obviously don't have, sufficient time to address each of these issues. So I'm going to focus only on this concern with human protection. So in this context, we do research trials that involve recruiting human subjects and then doing interventional studies or observational studies. It might depend. with human subjects. So this is the aspect of research ethics that I am going to focus on here. But again, if anybody has any questions about any of the other issues, please let me know. So we have both ethical principles and, again, federal regulations and state regulations also to regulate research when we do research with human subjects. So part of the reason, part of the history of these regulations is related to abuses that had happened with human beings in research. So I'm sure most of you might have seen some of these pictures. The first one, this one, is an experiment during the war. The Nazis did actually infamous experiments with human beings. But the rest of them are actually experiments done in the United States. This one that I am pointing to now is a photography of one of the most infamous experiments in the United States. Is the Tuskegee study that lasted for about 40 years. Where African Americans were recruited for this study to initially study the natural history of syphilis, but eventually when a cure was found in penicillin, the people who were, the men who were actually recruited for the experiment were not given treatment. So this was discovered, or we heard about it in 1972 after one of the researchers at the Public Health Service tried to get the study stopped. When he couldn't do that, went to the newspapers, and the newspapers made this public. This was a huge scandal in 1972, which gave rise to the Health Act, the Research Health Act, that actually charged a committee, what is called the Belmont Report, with proposing ethical principles to regulate the conduct of research. These two are also experiments in the United States. This is also an infamous experiment in New York, actually, where people, elderly people with no capacity to consent, were injected with cancer cells. This was in 73, I think it was. And this is a photography of also experiments with radiation that lasted also for about 40 years during the Cold War, where the object of those experiments was actually to evaluate radiation, how radiation affected human beings, this also without consent from the people recruited. There are unfortunately many other cases, and I'm happy to talk about any of these cases, you know, in more detail if any of you has any questions. And again, please do interrupt me if you have any questions. And these are just the names of the studies. So after,
excuse me,
yes,
Doctor. There's a new documentary out on the life of Dr. Oliver Sacks that some may be aware of. Just in case, was a medical doctor, researcher, scientist, and then actually became, of course, very famous for his use of creating narratives in connection with each patient as a medical history, and then developing that into the general lexicon, the commerce, if you will, the marketplace of media for lay people. But in particular, Doctor, thank you. My concern is if you could reflect on his use of dopamine on patients who had gone seemingly out of contact consciousness with reality, who were placed, warehoused essentially in a remote part of the Bronx in a hospital setting. If you could reflect, while it was considered daring at the time and had some modest and incremental impacts on bringing both of these people, or many of these people who would be classified as out of it, back into some relative connection with reality. Doctor, in your view, now with the hindsight of a half a century of ethics development, how might that be viewed today, Doctor? Picking up on your point of lack of ability to truly give informed consent. Thank you.
Right.
Doctor.
Right, thank you. So it is, as we will see, it is actually very difficult even today to provide what many might consider a valid informed consent. It's very difficult for a variety of reasons, so I will go over them. I don't know that it's more difficult now than it was in the past. Some of the barriers that we have now were obviously present in the past. We certainly have more attention to these problems, so that might be helpful. In the past, as today, clinicians have a significant amount of leeway to use drugs that are approved, even in ways that, for things that were not, the drugs were not initially approved for, so what is called off-label use. That use of drugs does not involve experimentation according to federal regulations. So this is actually the way in which we normally use drugs for children. The majority of drugs are not tested in children for a variety of reasons. So when doctors actually prescribe drugs to children, they have to guess what might work for the kids. And this is allowed and does not constitute experimentation. So again, this was the case in the past and is certainly the case today. But so this issue about informed consent is actually very important, and I'm going to show actually some of the concerns that arise in that context, in the context of informed consent. So there are three principles that, after the Tuskegee experiment, again, the Belmont report the commission was charged with developing a report that would give us ethical principles that we can use to design research with human subjects and to evaluate research. So IRBs, institutional review boards, for example, are in charge of reviewing any research that is done at institutions so that we can ensure that the research fulfills these ethical principles. Researchers also are required to meet these ethical principles, but just in case they don't, the IRBs are charged with ensuring that that is the case. So the three ethical principles that are used to, again, either design or review research are the following. One is respect for autonomy. That it's a principle that calls for researchers and IRBs to ensure that people are able to choose according to their own desires. The way in which we normally implement this principle is through the informed consent requirement. So I'm going to name the three principles, and then I'm going to go over each of these principles and see some of the problems that we have in meeting the requirements that these principles call for. The second principle is the principle of beneficence. It's actually a combination of beneficence and non-maleficence. So this principle requires that if we are going to put people at risk, we can do so only if the risks are reasonable in relation to the anticipated benefits. So the way in which we instantiate this principle in research is by ensuring that the risks and benefits are balanced in appropriate ways. We also require researchers to minimize risks to subjects participating in research and to maximize potential benefits, either to subjects or more often to society, given that a significant amount of research does not benefit the people who are participating in that research. And the last principle is the principle of justice. This principle requires that we distribute in fair ways the risks and the burdens of research. The ways in which we normally put this principle into practice is by ensuring a fair selection of subjects. The experiments that I just mentioned, you know, the Tuskegee or the Jewish chronic experiment or the radiation experiments, all of them failed. All of these principles, or some of them, the Tuskegee, for example, you know, failed to meet all of these principles in various ways. So what I want to do now is go over each of the principles a little bit more detail and see what some of the problems are that we face in trying to fulfill these principles. Also, when we recruit subjects, and if we have again time, we might discuss a little bit more about this. We have both, you know, for ethical reasons and federal regulations, we have special requirements when we recruit vulnerable subjects. And although it might seem that many people could be considered vulnerable when they participate in research, for example, sick people could be considered vulnerable. Vulnerable subjects are a category of people, groups of people according to federal regulations. So not just any subject is actually a vulnerable subject. So children are considered vulnerable subjects. Pregnant women are considered vulnerable subjects. Prisoners also. And people with cognitive impairments. So those are the vulnerable subjects categories that are regulated. So as I was saying, I'm gonna just talk a little bit more about each of these principles. So this principle of respect for autonomy, as I was mentioning, is, you know, autonomy is the ability that human beings in general have to act freely according with some chosen plans. So it's very important to human beings to be able to act autonomously. It is very important, it's in many ways central to what it means to be a human being. And we can say also that in general, autonomous choices actually allow us to promote whatever our ultimate goals might be. So normally we know ourselves the best. We know what our values are. So, you know, it's more likely that if we are allowed to choose according to those values or preference, in general, you know, we would be able to meet our goals. In the context of research, it's not sufficient that we allow people to choose. We need to do more. We need to actually foster the conditions that allow people to make autonomous choices. So it is not just, okay, do what you want, is we need to create the conditions that would allow people to make autonomous choices. In that context, it's the researchers' job actually to do that, to ensure that they enable, that they foster those conditions. And the way in which we, again, implement this principle is through informed consent, through the practice of informed consent, the process of informed consent. in the context of research, again, this is obviously the case also in the context of clinical care, though in most cases, if we just go to the doctor for a normal visit, we might not sign anything. If you have a surgery or something that involves more risk, people also would have to sign informed consents. But in the context of research, the standards of consent are actually stricter than in the context of clinical care. And the reason is that in the context of clinical care, the assumption is that the individual patient is going to benefit potentially from the participation from the clinical care that is being given to her. But in the context of research, participation in research may involve no benefit whatsoever to the particular individual. And so we want to ensure that people understand what the risks might be. And so that's the reason we have stricter standards for informed consent. So what does it mean to give an informed consent in this context, in the context of informed consent, of research, sorry. So one has to have capacity to consent or have competence. Competence and capacity are often used interchangeably, although they have different meanings. Competency is a legal concept where capacity is a psychological one. So one is declared incompetent by courts, but one can be said to have, to be incapacitated by a healthcare professional. So they can actually determine that a person doesn't have capacity to consent. So this is a threshold element. Before we can ask for consent, we need to determine whether the person is either competent or has capacity. There might be some people actually who might have capacity, might be considered to have capacity, but who are incompetent to consent. So for example, a 17-year-old might have the capacity to consent to at least some interventions, but they are incompetent on legal terms. So that's the reason, although we use these terms interchangeably, they actually have, specific meaning. So once we have ascertained that someone has capacity, then we need to ensure that we offer the potential participant appropriate information. So disclosure of information is a requirement of a valid consent. That's the reason we talk about informed consent. So we disclose the information to the potential subject. We also need to ensure that the subject actually understands the information that has been provided to her. So it's not just that we read a consent document and then just say, okay, here's the information, now you can consent. We need to make sure that the person has understood the information that we have provided. We also need to ensure that the person is acting voluntarily, so that there is not either coercion or undue influence or manipulation that might actually lead people to participate in research when in fact they don't want to do that. Once we have ascertained that the person has capacity, we have given them the appropriate information, we are sure that they have understood the information and that they are acting freely, then the person can consent to the intervention or the research. And in that context, we talk about a free and informed consent. If the person refuses after all of this process, we talk about a free and informed refusal. So free and informed refusals are also good. And sometimes, are the appropriate response if someone has judged that the risks are just too high for the person, or that they don't like the research that is being done. Okay, so, but this is what it's meant by a free and informed consent. Any questions about this before I continue with some of the problems?
Yeah, I have a question.
Yes, please.
So I kind of look at this as a process. So let's say they, decide yes, but then later on, you know what, this is not working out for me.
Yep.
And I do that refusal.
Yes. Yes, because consent has to be voluntary, one of the things that appear in any consent document actually is you are free to stop participating at any time. So you might consent to participating in a study. Imagine that it's a study that takes, you know, a few weeks or months in some cases. And after you started with the trial, you know, you think this is too burdensome, or I don't have the time, or, you know, I just don't want to keep participating, you can stop participating at any time you wish. Depending on the particular trial, the researchers might ask you to do a final visit, particularly if the clinical trial involves an intervention, to make sure that you are okay. But otherwise, precisely because of this voluntariness requirement, people ought to be able to be free to stop participating at any time they wish.
Thank you.
More questions? Okay, so this is the ideal situation. This is what we want when we go through the process of informed consent. Again, informed consent is not a particular event. Normally, people tend to associate consent with a signature, but that's not what ethically, from an ethical point of view, we think of as informed consent. It's a process where people have to understand information, again, make sure that they are acting freely and making decisions as they go along.
Can I ask a question?
Yes, yes, absolutely.
How do you know if they're psychologically also able to be part of this? Is this going to fall under the competency and capability aspect?
Correct, yes. So that capacity, so in general, the assumption is adult human beings have capacity, are autonomous entities, and therefore they have capacity. That's the assumption. Only if there are reasons to believe that capacity is not present do we assess capacity. But otherwise, the assumption, for good reasons, again, the assumption is that it's good for human beings to behave in autonomous ways, and therefore the burden of proof is on those who want to say that someone is not capacitated to give a consent. Capacity is not an all or nothing phenomenon. So some people might have capacity for some things, but not for others. And in the context of research, capacity, assessment of capacity is particularly important when we recruit people who might have fluctuating capacity or who might lack capacity. So for example, if we do studies with people who have some mental disease, mental illnesses, so in some contexts, mental illnesses might reduce people's capacity. And in that context, we would require that researchers have some way to assess the capacity of subjects. If a subject doesn't have capacity, or potential subject is thought not to have capacity to consent, then we require a legally authorized representative who could consent on behalf of the subject. But indeed, that assessment of capacity is prior to determining, again, to giving people information or doing any of these other things with the subjects.
I have a question.
Yes.
Okay, so with keeping all of this in mind, the capacity to act and such, if a person passes away, but they're, how should I say this? You know how a person passes away, but they're still alive for a certain amount of hours, technically? You ever heard of that? Yes or no, or you haven't heard of it? Or
I know that I know of, but even if that was the case, the person would be incapacitated in the sense that we wouldn't be able to actually determine what their desires might be. Yes.
Okay, good. All right. So you answered the question in that, but there was a situation where a person was medically dead, like they passed away, right?
Okay.
For, I would say, at least they looked like such, right?
Okay.
And I was in the hospital room, and I didn't, you know how you see something, but you don't see something because you're doing something else. So we were praying over the body. And as we were praying over the body, this particular, I'll be right with you, okay, Mom? Yeah. So as we were praying over the body, this particular nurse was sitting down, and she was taking blood from the patient. Is that normal?
From a different one?
No. She was taking blood from the person who was supposedly medically dead.
So that would be a context of clinical care, not a context of research. So, I mean, we normally don't take blood from dead people. So yeah. I'm not exactly sure what the nurse, it might have been that the person appeared dead, but it might have been in a coma or in a vegetative state.
They were said, we were called to the hospital and said that they had passed away. And that's why we was at the hospital. That's why we was praying.
Yeah,
and the other thing is that, you know, I'm not trying to create this crazy thing, but you know, there's sometimes there's things on your minds, and this created a perfect opportunity to ask questions. So that's why I asked.
Absolutely.
So in that sort of situation where someone is classified as passed away and then blood is still being taken, would you find that unusual?
I find that very unusual. Yes, I find that very unusual. But again, that would not be research in any case. It would not be a context of research. That would be, you know, in a hospital with people doing what presumably is clinical care. So
okay, so how could it be clinical care if the person was already classified as passed away? And how
which is why it would be very strange to have someone, you know, being taking blood from someone who is dead. That would be very strange.
And the other thing is, why would they take blood from someone if it's not for research? They're going to use it for something.
Yeah, I mean, we would have to know the details of the case. I don't know whether perhaps they were trying to see why the person had died, and you know, they were checking whether there was an infection, or I have no idea, obviously.
All right. So is that something that they would do if a person was classified as dead? They would take blood after to find out why they and how they died?
Again, that seems very odd to me, but I can imagine some situation in which if the person just comes and, you know, they are trying to determine why the person died or something like that, and they wanted to evaluate, you know, I can imagine something like that.
Okay, well, I appreciate your answer.
Sure,
thank you so much. That was I heard you. Okay.
Thank you.
Thank you.
So in this context, again, in the context of research, this is what we do when we obtain a free and informed consent. Now, we have significant amount of problems actually obtaining free and informed consent, particularly for clinical trials that involve significant risk. So one of the reasons is that we have consent documents that are extremely long. And it is very hard, you know, when you have a very long document, to give an informed consent. Can anybody tell me why that might be the case?
No one reads them.
Exactly. No one reads them. So there is lots of research done on informed consents, and you know how appropriate they are for people to be able to make autonomous decisions. And we have been doing research for decades now, and the evidence suggests that our consent documents are actually getting longer rather than shorter, more difficult to understand, and making harder for people to make decisions that are actually autonomous decisions. So, but indeed, one of the reasons for this is that very long consent documents are unlikely to be read by people, simply, you know, because they are very long. So that's one problem that we have with consent.
And Doctor, could I ask you a quick question on the topic of foreseeability and lack of foreseeability, as well as it relates to risk, as well as tangible and intangible risk, isn't part of the pushback on the legal side to shore up and buttress against any lawsuits. Of necessity, the length of the documents has exponentially expanded because, doctor, in fact, much risk is both tangible and intangible, quantifiable and unquantifiable, and foreseeable and unforeseeable. So there's that tension, doctor, between what one knows and what one has to acknowledge as a researcher, that you cannot know what you don't know.
That's correct. Yes. So that's one of the reasons actually for the increasing length of consent documents. So part of it is the legal requirements. Institutions want to ensure that everything that needs to be said is said in the consent document to avoid liability. And research is becoming more and more complex. So it's also actually, requires more information. And in the context of risks, you might have many risks from a particular intervention or a new experimental drug, and you want to ensure that subjects have information about those risks. And of course, you also want to tell subjects that there are many things that we don't know, particularly when we are doing initial research with a particular drug or intervention. So there are not just things that we know might be side effects. There are also things that we don't know whether, something might be a side effect because we don't have still enough experience with a particular intervention. So indeed, that's one of the reasons why the consent documents are getting longer and longer. We also have not just our consents are very long, actually they might, even in the context of very long consent documents, they might be incomplete. They might not have information that is actually necessary for someone to be able to make a proper decision. Sometimes they might be unclear. That's actually very common because the level of the reading level might be very high. Federal regulations, for example, require that consent documents be lower than the 8th grade, ideally between the 6th and the 8th grade. But many studies that have been done evaluating consent documents say that the average consent document is around a 10th grade, which make it very hard for many people to actually understand. They might have very complex information, in part, again, because research is getting more complex, but also in part because it's very difficult for researchers to put scientific information in terms that lay people are able to understand. So this makes it hard. So we might be disclosing appropriate information, but in ways that are difficult for people to understand, or we might actually be failing to disclose information that is necessary for subjects to have. There is also a lack of commitment to informed consent actually as a process. So this is a serious concern. We tend to think, again, associate the consent with a particular moment, which is when people sign the document. So the second principle is the principle of beneficence, and this principle also, has, as I was mentioning, is this combination of a duty to do no harm, which of course doesn't mean literally that you shouldn't do any harm, because there's nothing in medicine, or very little in medicine, that cannot that would be completely safe. But it's a principle that actually requires this balancing between risks and benefits. So you maximize benefits or potential benefits, and minimize harms or potential harms to participants. The way in which we apply this principle is ensuring that the research that is done has social value, so that we are asking questions that would give us important information that is important for communities, for society to have, or that we are testing interventions that might improve the health or the well-being of people. So social value is one of the ways in which we can ensure that there will be potential benefits to society. We also want to ensure that the science is valid, so that we are, using appropriate methodological requirements, and that we are designing our experiments in appropriate ways, so that we can have valid results from the research that is being conducted. And then again, that we assess the risks and benefits of the research. So we require that researchers design research in ways that minimize risks to subjects who are participating, that maximize possible benefits to subjects when those might exist, and certainly that they ensure that there are potential benefits to society, and that the benefits actually outweigh the risks. So this is the assessment of risks and benefits. We also have concerns, in the application of this principle. It is very difficult to assess risk and benefits. As we were just saying, one of the reasons why this is difficult is that sometimes it's difficult to determine the risks of a particular intervention. We just might not know. This is particularly the case when we are doing first in human trials. So, it's the first time that we test a particular drug or intervention in human beings. And we only have information that we have gathered from animal studies. And often animal studies are not very good at giving us sufficient information about what might happen with human beings. So things that happen to animals, side effects on animals, actually might not happen in human beings. And things that are not bad for animals might actually be bad for human beings. So it's very difficult in that context to give appropriate information and to assess risks and benefits in appropriate ways. Another problem is that often researchers or research communities in general actually overstate the potential benefits of the research to the particular individuals who are participating. This is a problem, obviously. If we are exaggerating the potential benefits, people are not making autonomous decisions because the information that they have is not correct. And sometimes the overstatement of the benefits is not intentional. Researchers are just trying to give information, but they want to ensure that people are not discouraged from participating in research. So we might use language that is not very clear, is vague about exactly what the potential benefits of research might be. So why do you think that this is, important, that if we have vague language about the benefits, or we exaggerate the benefits? Why do you think that researchers might do that? Either, again, sometimes not intentionally so.
Well, isn't that the whole point of research? You don't know. You don't know what the outcome will be until you do this testing.
Right, you don't know, but presumably you have some reasons why you're doing the research. This is the potential benefits of the research. Mm-hmm. So you want to tell subjects. Yes.
No, excuse me, Doctor. One potential reason is to attract funding sources, both institutional, external, private, and public, that if you can get a buzz and an excitement and use your research as a magnet to progress a larger societal need, you put your best foot forward and you put a little extra maybe spin and polish on your presentation in the hope that you can win over the largest number of stakeholders to support and advance your work.
That's correct. So indeed, one of the reasons why we have, we try to express, in the best possible ways what the benefits of research might be, or potential benefits, is because that's a way to get funding for our research. But it's also a way to recruit subjects. It's unlikely that as many people would be participating in research if they didn't think that there is some potential benefit of participation. And again, potential benefits need not be necessarily to the individual person, or to their health. In some cases, people might have, altruistic reasons to participate in research. They just want to help future patients and society in general. So, that would be obviously a reason also to ensure that we have appropriate information about benefits. But our consent documents often overstate actually these potential benefits. And also this failure to realize the importance of emphasizing possible benefits actually to society as a main reason for the study. The main reason for conducting research is not to benefit individual subjects who are participating, is actually benefiting society or future patients. So that's very important, so that subjects actually have information about the fact that we are conducting research in order to benefit future patients. And finally, there's the principle of justice. As I was mentioning, the principle of justice in a general way requires that equals be treated equally, and that unequals be treated unequally. And of course, the issue is to fill in the blank. What does it mean to be equal or unequal? In the context of research, we are concerned actually with distributive justice. And in that context, what we are concerned is the allocation of resources when we conduct research, but also the distribution of benefits and burdens of research. Allocation of resources is important. If conducting research has opportunity costs, if I use the money to do this research, I cannot use it obviously for other research. So the practical applications of this principle is, as I was mentioning before, ensuring that we have fair procedures for the study, to select subjects to participate in the study. So we develop appropriate inclusion and exclusion criteria. The inclusion and exclusion criteria should be grounded on scientifically and medically relevant information rather than on social characteristics. We ensure that subjects are selected so as to minimize risks and enhance benefits when those are going to accrue to the subjects. And again, that we distribute the benefits and burdens of research in fair ways.
I have a question. I'm sorry.
Yes,
please. No, I can wait. I'm sorry. I didn't know you was going on. I'm sorry. I can wait.
If you have a question related to the fairness issue, is fine.
It is. It's related.
Okay. Yeah. So
and speaking about justice, I was very curious because with the situation with Henrietta Lacks and her family, after she had passed on, and they had these cells that could stay in the petri dishes forever. And at that time, I think it was if you could correct me if I'm wrong, 1940s, 1950s, her cells were sold throughout the world at that time.
Yes.
And they're still being sold till this day. The family had no knowledge of it, and till this day, they're not being compensated. Yeah. And I know that the family had stated that, it's important for, society to benefit from her cells, and we want people to know, and this, that, and the other. But at the same time, there's a certain amount of justice concerned with that, you know, as far as their children, as far as themselves. I mean, it was what they did was horrible.
Yeah.
Not only that, being that they know that they were wrong.
Yeah.
It's 2021. Okay, so just because the rules were not made, or these procedures and so on was not made until afterwards, does not mean that what happened then was wrong. So this should be justified. To me, this should be justified in the courts, right? People really need to know more about Henrietta Lacks, because if it wasn't for her, there's so many vaccines that we would not have had. Not only that, they used her cells for the COVID vaccine. And I'm sure many people don't know about that. People need to know. They need to know this woman. They need to know what happened to her, and she needs to receive justice, whether or not, so even though she has passed on.
Yes.
And,
yes.
And that's, and you know what that is? That's being human.
Yes.
Okay.
I agree. Yes. So, so indeed, the HeLa cells are actually some of the most commonly used cells in laboratories. Many discoveries have been done with those cells, and indeed, you know, the way in which the cells were obtained is ethically problematic. They were obtained without the consent. And indeed, the family has not been compensated. Importantly enough, we do not compensate people in any context, not today either. So if we obviously require consent, but one of the things that consent documents indicate is that if any discovery results from your participation, or from your tissue, or from your blood, or from whatever it is, those discoveries, you are not going to be receiving financial compensation from those.
So if billions of dollars have been made in selling her cells, I just don't understand that.
Yes.
And especially since they was taking unbeknownst to the family, right?
Yes. Yes, unbeknownst to her in particular, who would have been the relevant person. Yes,
right. And they never called her did they ever call her? Was she ever classified an experiment?
No. The cells were taken for clinical purposes. So those cells were taken because she had cancer, and the cells were taken to evaluate her, obviously, for clinical purposes. And then it was discovered that the cells were actually fantastic in reproducing.
Right.
And so they started.
That I understand, but they were never taken with the premise of being for like a trial or
no. Okay. They were not taken for I mean, again, they were taken to do for clinical reasons. She was not as a research subject in a clinical trial. She was just a patient.
All right, and I have one more question related to what we're speaking of now. Her blood type was RH.
I don't remember what her blood type
was. Okay. It was. I read it. It was, right?
Yeah.
And I don't know how much you even know about her. I just don't. I mean,
I know quite a lot. Yes.
Okay, good.
But I don't remember her blood type. Yeah.
Okay, so the reason why I bring up the blood type is because I would like to know if her blood type was RH before she went in, and I would also like to. I'm interested to know the blood types of her family members, because there are certain cases where a person could get an organ transplant and their blood type change because of the organ transplant. I did not know that. But
I don't know. I have no idea what her blood type was, or certainly what the blood type of.
Okay, well, when she died, it was RH, but I would be interested to know what it was before that, because what that would tell you is that there was some sort of other, interference in terms of her regular normal state. They would have to have done something else to make
perhaps yeah. Again, she had cancer. The cells were taken to evaluate her for clinical care, and it was only with this evaluation that it was discovered that the cells behaved in ways that made experimentation very good. But again, as I mentioned, this is not that something that happened only at that time. Again, at that time, the problem was that she was not asked for consent for those cells to be used. But there is no, today, again, consent documents explicitly state if there are discoveries that would result from the participation, again, your samples, your participation in a clinical trial, people are not compensated for that.
Right.
And that's a question of justice indeed.
Mm-hmm.
And, there are many reasons to argue that that is unjust.
Right.
And there are reasons to argue that if we were to compensate people for participation, then drug companies, for example, would have no incentive to do research, and it would be bad for everybody. So so we could give arguments on both sides for why it might be appropriate not to compensate, but but it's a serious argument behind
but
it.
I'm not thinking about compensation in the fact that they made billions. I'm thinking in terms of like a lawsuit. If there was a lawsuit, how much would her family be given? I'm not asking you that.
There wouldn't be any lawsuit. Again, there would not be any possibility for a lawsuit because you sign a consent document that says you. No,
they did not sign
at that time. Yeah, indeed, the family. Yeah, the family could have sued the public health service for actually Hopkins for having used the cells without the consent of Henrietta Lacks, and it seems that was the case, and there was some settlement that is confidential. So I don't know.
I'm sorry, but that was very lacking. That whole situation was very lacking. Unfortunately, I don't think the family was
appropriately compensated. That's absolutely.
Well, no, I'm not. I wasn't getting ready to say that. I was getting ready to say I don't think the family was. I don't want to say intelligent, but a lot during that time, a lot of people did not know their absolute rights. If they had absolute rights, but you know what? Today we have rights, and we need to go back. I'm sorry. A lot of people say, well, it happened a long time ago, and it helped so many people. But it's like the same situation that played out then can also play out today because it was never corrected.
That's
and listen,
correct.
Let me tell you something. I want to say, and you already know this, you're doing a great job to come up here and to get the questions.
Thank you.
Because we know that you don't know everything, and you know that there's a lot of information out there, and so I just want to thank you. I just want to thank you. And my research, my community and person in society research continues because it is important.
That's great.
And I thank you for giving us your good energy today and answering the best that you can, I should say. Thank you.
Thank you.
So I'm just going to interject. Mia said that she asked a question, but how does it make just that they still use her cells even if it's for clinical research? And then Diane can go after.
Yes. So why is it fair? One might say many people, millions of people have benefited actually from those cells. So if we think, one could argue, and certainly people have argued, that as human beings, we have a duty to other human beings, particularly if that is not very costly to us. Seems clear that it was not very costly, at least in some sense, to Henrietta Lacks for those cells to be taken because they were taken for clinical purposes. And that millions of people actually have benefited from it. So if it is the case that we have this duty to be altruistic and to benefit other human beings with our actions, and again, particularly when that's not very costly to us, then that would make the use of those cells just. Still, even if that's the case, we could still say that the way in which the cells were taken was ethically inappropriate. But it would be difficult to say that because it was ethically inappropriate to take those cells without consent, that we shouldn't ever use them again. Though some people might argue that. So, but that's the way in which one can say that it is still appropriate to use them given these duties that we might have to other human beings. Agnes, you said that there was some other question?
Yes, Diane has her hand.
Yes. Okay, just wanted to speak to a little bit of that response and to Jazzy Janelle, who was speaking, and maybe even the question. I think part of what the challenge is as we approach community research is Henrietta Lacks happened to be a Black woman of African descent.
Yes.
And so it's how people are valued. When we look at, as you started out with in the beginning, the history of how some of these, the most egregious experiments or studies happened, it wasn't how they valued the person as a human.
That's
and
correct.
Who they valued. And so part of what I hear being stated is, yes, it benefited more people. I think you just said like the cells, it cost her less to donate the cells than not. But we have, if we think about in the context of who she is and who she represents, with that same attitude, the same approach to getting the cells, the same lack of information or other expanding what the consequence could be or how it could be used, or even that the family, in the case of the settlement, did they have the same understanding? When we look at the way that structural racism or the value of people are treated, approach research, I think that hits to the core of it. And that in terms of justice, even, is it justified? Oh, for her family, that was good enough, even though it's not, it was some compensation, but not sufficient. And if they were not Black, would that compensation have been different? Would they have the resources that have been denied them to advocate for? So I think that for us, because that's what we're facing with the vaccine, right? The current vaccine and COVID. So for those of us on this call and looking at becoming more as community researchers, is understanding that structural nuance and who's valued, who's deserving, and how we share information. And that's key.
Yes. That's absolutely right. Yes, indeed, we have, you know, many of the problems that we have actually, you know, in this, I'm just going to put it here. Sorry. You know, some of the problems that we have with justice have to do precisely with those structural issues, and structural racism is one of those aspects that prevent people from, that prevent research from being done in just ways, and that prevent people from actually benefiting from the goods of research. So for questions of access to the benefits, who has access to benefits of research? You know, if people don't have insurance, for example, can they have access to the benefits of, you know, medication? Who is being burdened by conducting research? What happens when we have deprived populations, and certainly in the context of global research? So justice is indeed a serious concern in the conduct of research, and questions about structural racism are certainly significant. Now, importantly, one of the reasons, there are two reasons why, you know, structural racism is relevant in the context of conducting research. One is because some populations, minority populations, might not benefit as much as they ought to from research, from the goods of science, but also because they might not be participating in research as they should. So they are not, for example, we have lots of information that indicates that minority populations, racial and ethnic minority populations, are underrepresented in research. And this is bad, you know, obviously because they don't have access to, you know, whatever goods come from participation in research, but also because then the drugs that we get or the interventions that we get have not been tested on those populations, and therefore, we might not have the general ability. You can not generalize as we would if we had an appropriate representation of the population. So issues about justice in the context of research are certainly very important issues and very difficult to address, actually. Agnes, I think there are some more questions.
Yes. So Diane just also added, also the profits of the pharmaceutical far outweigh the cost of compensation to the individual. And Jewel Jones has her hand raised.
Yes, and let me say, yes, that's the case. The pharmaceutical companies obviously get lots of benefits. The argument is that if they had to compensate participants, then they would get less benefits, and then they would not have interest in participating or in conducting research. So whether we buy that argument or not, it's a different issue.
Okay.
This you open up a whole other because oh my goodness, when we talked about the last person who brought up the not valuing individuals, and then you start talking about structural racism, and then you talked about the underrepresentation in research, and I think obviously that Black and brown individuals should be participating in research, because obviously you need that diversity in terms of the population. But then you talk about why, because and then please forgive me, medical professionals, but there's that obviously that the distrust and reasonably so, and I'm in the medical community as a whole, and even to this day. And I mentioned J. Marion Sims, and that I think you should add that to the curriculum, because this individual, of course, it happened way back in the 19th century, but in terms of these three women that were that he you know what, because his belief was that Black women did not experience pain, and then they believe that like the brain structure of the skull, so when you have these biases of medical professionals, maybe perhaps to this day, where I believe it does happen to this day, and that's terrible. If a Black person walks into a white doctor's office, he immediately says, okay, well, I'm going to go this route because this person is Black, in terms of, I don't know, drugs, in terms of, testing. And so there should be something done in the medical community, in terms of, when you go to, you're educated and have anti-bias training.
I agree.
So this is like a whole other subject. Sorry.
No, I actually teach medical students. So, and one of the things that I do in my classes is call attention to both racist and sexist bias, and a variety of other biases that exist in the medical curriculum and the medical community, and the ways in which this obviously affects health outcomes for patients, for minority patients, for women, for pregnant women, for all kinds of groups, precisely because of the kinds of biases, many of them implicit biases. So people need not be, just everybody being racist, intentionally racist. But we live in a context where racism is present every day and everywhere. So, good people, whether they realize it or not, can behave in ways that certainly contribute to those racist structures. So this is a question. Obviously, I understand that there are good reasons for minority populations not to participate in research because of these issues regarding trust and, what's going on with the medical community and the research community. But it's not good for minority populations, not to participate for these other reasons. So
that's right. That's yes.
Okay.
Thank you.
A few more comments. Sorry, let me just scroll up, and then Paulette can speak. Mia said, I think it's more of a distrust from the institutions, especially when it comes to when we see these historical unethical cases. Ms. Wilson agreed with Mia, and then Diane said, yes, Joe, definitely. Its skills happen today, especially with pain management and maternal mortality in Black communities. And then Mia said, how much are they emphasized though? I know in my engineering courses, we are required to take at least a single class on ethics, which I don't think is enough given how complex technological advancement area. I plan on applying for med school, so I am just wondering.
Yeah, at Cornell, at least, we have 4 years. Every year of medical school has a course in ethics. So I still don't think it is sufficient, but certainly more than it used to be the case. So they start in the first semester with ethics, and until the last year where they do transition to residency, where they also have ethics classes. So still, medicine is an intrinsically a profession that requires, ethics thinking all the time. And the same with science, with research, particularly research involving human subjects. So I don't think anybody would be hurt by having more ethics courses.
Yeah, and then Diane just also added, so what are some of the solutions as we approach or learn about community research? There needs to be more directive focus to address it.
I agree. So, so each of us can perhaps contribute in different ways. I hope that, the way in which I contribute is by doing these things and making people aware of what our rights are and what kinds of things can be done. And, different people can have different roles in trying to ensure that we have a scientific community or a research community that actually attends to the needs of the people rather than to the needs of, pharmaceutical companies. So it's important that there is pressure from communities to determine what kinds of aspects of our health and our well-being are relevant and what things should be studied.
Okay. Hey, Inma, it's Jeff. If I could just interject with one comment to everybody. I think one of the things I want to make everybody aware of is that Emma has done a very good job. She and people like her have done an extraordinary job of not just revising our medical school curriculum, but ensuring that this ethics and these cultural awareness and all these problems we're talking about are addressed in the medical curriculum and taught to future physicians. Now, the problem with medicine is that, like many other fields, it's dominated by extremely old individuals, I guess older individuals, I call them older individuals.
Careful there.
Yeah, who did not receive this same sort of training in their education. And so I think a lot of the sort of disconnect we're seeing between, why is there more action? The people being trained today and for the last 10 years, I would say, are very aware of these issues and want to address these issues. But because we have not trained the people who are the leadership and in charge and the decision makers, the senior individuals the same way, a lot of what you're seeing is, is stuff that will hopefully be addressed in the future when our current medical students and the ones who have recently graduated get advanced to leadership positions and have decision-making power. We'll see a lot more change. I strongly believe that. But, I agree. This change is slow, and I agree. It's taking forever for these changes to happen.
Yeah.
But be aware that, we are trying as a medical community to address this, but unfortunately, because the people in charge, we're not given this training. It is the fastest process.
Okay, well, I would just like to say too that we should look at it like a ethical license. So in other words, someone who was taught way back when, it comes a time when they have to maybe take that ethical exam again. It will give them enlightenment to current events. It is totally, I'm sorry to tell you, but it's not an excuse, because when a long time ago, when they learned such and such, the information wasn't available. I'm sorry, it's here today. And that's what I mean. And that's what I mean when we say we can make these corrections. So as far as ethics are concerned, they need to know. Period.
Yeah, I think that the problem is not just individuals. This is not an individual problem. It's a systemic problem. And so sometimes, even when individuals might want to do the right thing, It might be difficult to do it because there is not the resources or the possibility of doing those things. So it's something that requires structural changes and not just individual changes. Although, of course, it also requires individuals to be committed to those changes.
It can be done. It can be done. I just think that it's not.
Hopefully so,
I just think that they don't feel that it's important enough. I think that, and it may be something that has to come out of the community. It may be, you know, a panel like this and people coming together and creating a book and creating a voice and going to the Senate, going to wherever you have to go to get that voice heard, because that's what this is all about. You know, you are here for the community. So out of this panel, I mean, there's so many intelligent people. Oh my goodness, listen to these women. I'm like, wow, right? They're here for a reason, right? You're not only here to talk, but they're also here to get something done, right? And so I believe that it can be done. It can be done with 5, 10 people just to start that book, just to get that action going.
I agree. Yep.
Hello.
We can't make excuses.
Paulette.
I just want to interject and say one thing. I believe everything that you're saying, and it takes one person. It takes a group of people. That's why the Community Research Academy, that's why you're here. That's why your voice needs to be heard. But it also means that you get involved more and more. And this is just the beginning. So, and everything everyone is saying is correct. But it requires commitment from the community. It requires commitment from you. And it's not an easy road. It's a long road. It's tenacious, but it's doable. And you can do it. The community can do it, but they have to agree to do it and want to do it. Because right now we have the COVID and everyone is interested. But what will happen when the COVID goes away? The community must still be at the table. They must still be involved. It's a continuous process. So I'm delighted to hear the comments. I'm delighted to hear the back and forth, which means 5 years ago, I don't think I could have gotten all of you at the table with the conversation that we had today. So I think it's a powerful conversation. I think it's a great conversation. And that's why when all of you finish this program, you will be invited to the table to evaluate, to participate, to get involved in translational research, representing the community, representing your interests and the community interests. Thank you very much.
I just want to say Paula had her hand raised, so she can go now. Sorry.
Well, okay. One last thing that I want to say. I want to say thank you. But the other thing is, I'm sure that many people in this group probably only heard of it because of COVID, right? Because the thing is, people, the doctors, everybody wants people to go out and get those vaccinations. So what this is creating a way for dialogue. Oh, we don't want them to be afraid to go to get the vaccine. That is what this is. So with that being said, the information that's coming out of it, the reactions that you're having are real people saying what they've been feeling for a very long time. True. So I just want to say, listen, I have a full-time job in education. I do other work, but I do, okay? So if I got to start it myself, start that book, whatever I got to do, I'm here. I don't know about anybody else. That's all I'm going to say, because I feel very strongly about it. I'm sorry. And this is how I feel today, tomorrow, and next week. And
I think it's great.
Okay.
I think it's great.
So it's not just talk for me.
Oh, good. Then I'm looking forward to seeing more and more of you. And that's
so
great.
I think if I could just jump in, I think that for there are people that this is new because of COVID, and there are folks that have been in the trenches for a while, but not having access to this environment. And one of the things I think I will also say in terms of the community being involved, that's great. But Jazzy Janelle just said how she's working full time and she's doing this extra. There's no payment to the community. It's constant free information. Give me your time, give me your interest, give me your intellect. And there also needs to be a way to address it, because when we're going to the community, we're also going to the very people that you want to include, that these studies desire inclusion in, and this is just a variation of what happened with Henrietta Lacks. And so that's the challenge. So part of us is, how do we disrupt this system? We don't have time to wait until the systems change, because the people that are being affected are us. So what should we wait for? For more people to die, for more people to be sick, for more people not to have access? And so if leadership is unwilling to change, the challenge becomes, how do they experience consequences to shift change? Because most people won't change if it's comfortable, and it's comfortable to be in those spaces.
That's true. That's true.
Paula had something to say.
Thank you. In terms of participation by our community in clinical trials, that sort of brings to mind the research program that I mentioned before, the All of Us research program, which was previously is under the Advancing Precision Medicine Initiative that was started by Barack Obama. A lot of the work that we're doing, or we continue to do, is actually bring the medical representatives from the medical establishment sort of in the same room or forum with the people from the communities who we would be asking to participate in research. So you can have a real dialogue about what the issues are, what the health issues are, what is the nature of the underrepresentation in research, and what are the consequences for the community in terms of not having medications that work for them.
Right.
And also discussing the issues of trust, and also hearing what the medical personnel have to say, and getting feedback directly from the public. And keeping that as sort of an ongoing way of sort of removing people and changing the power dynamic, because a lot of the issues also it's about power, because it's the perception that physicians sort of store all the power about the population, and the population is sort of afraid or don't have the opportunity to speak to physicians sort of on a one-to-one basis. So some of the work we're doing is to try to sort of bring down, get rid of the walls, so that in a very informal way, you get more than just the 15 minutes of your doctor in an office. You get a whole hour to have a discussion online like this, and to ask questions. And so I've done quite a few of these interviews, and it's been very refreshing to hear the ideas of the doctors who are also the researchers, talking about the issue of people of color, and they themselves being people of color, and how they need to have more of our community being the actual researchers, and being research participants. So I think that part of this has to do with bringing people together on an equal playing field, and also letting people know what questions to ask if they go to participate in clinical trials. I mean, I recently I'm starting to interview community members who have participated in clinical trials, for them to talk about their experience, to answer questions about what they would tell people who are considering participating but are nervous. And one of the issues that comes up is consent. Specifically when it comes to risk versus benefits, how important it is to understand whether or not the participant will be expected to pay any hospital bills if something wrong happens. Little things like that come up that you only get if you interview a person who's actually have the lived experience as a person of color who's participating in a clinical trial. So these are some of the things that we're doing, but I think that communication is key, and the issue of power and trust is also very important, and having dialogue outside of the traditional settings, I think, tends to put people at ease, and you allow people to sort of finish their thought. You don't cut them off, after minutes. So that's all I have to say.
I agree. Yes.
Okay, so we've gone over our time today for the class. So if anybody has any extra questions, they can email me, and I can email them to Dr. de Melo Martin. And then
I have just one more comment. This is Lula May, and that is I'd like for everyone to start to get ready for their photo novella project that comes up in about 4 weeks. And in 4 weeks, what I'd like you to start to do is look around in your community right now and take pictures of not of anyone's face, or take pictures of things that move you, things that stick out to you, and write about those things and send them in to Agnes, and she will forward them to Dr. Elizabeth Cohen. And I thank all of you. We had a lively discussion today. I enjoyed it. Dr. Immaculada, I've always enjoyed your presentations. It was beautiful. I enjoyed the conversations, and I enjoyed the passion most. Now let's use that passion.
I did too. So it has been a pleasure. Thank you, everybody.
Thank you, Doctor. Thank you very much.
Thank you. Thank you. Bye.
Thank
Bye-bye.
you.
Bye.
Thank you. Bye-bye.
Thank you.
Bye, everyone.